Hi, very good morning. I'm Dr. Janak Patel. I'm general physician, MD general physician. Today we'll be discussing on one of the another very interesting topic we call as ARDS, or also word utilized is non-cardiogenic pulmonary edema. Previously it was called as adult respiratory distress syndrome, but you do see also in children, so now it is the word utilized is acute respiratory distress syndrome. There are other terminology which are almost gone. It was also called denang lung or shock lung, traumatic lung, weight lung, etc. Yes, they are definitely acute. This one is very acute. This one is also very acute. But this is acute, acute respiratory distress syndrome, where you see bilateral opacity, uniform opacity, or it is also used word ground glass opacity, and along with that you get severe hypoxia, not due to cardiac etiology, then we call that as acute respiratory distress syndrome. These are all different names, multiple names: acute hyaline membrane disease, congestive atelectasis, progressive pulmonary consolidation, hemorrhagic atelectasis, pump lung, shock lung, weight lung, white lung, denang lung, post-traumatic lung, stiff lung, adult respiratory distress syndrome, hemorrhagic pulmonary edema, non-cardiac pulmonary edema, oxygen pneumonitis, oxygen toxicity, post-perfusion lung, ventilatory associated lung injury, etc. These are all lot of different names were given. Now at present only one name which is utilized is acute respiratory distress syndrome. So there are 5 clinical features which is in favor of ARDS. 1. A risk factor for the development of acute respiratory distress syndrome, that is sepsis, trauma, pneumonia, aspiration, pancreatitis. This comes topmost on the list. Because of that, it results into severe hypoxia, where relatively high fraction of inspired oxygen, so FiO2 becomes high. There is a decreased lung compliance. Bilateral pulmonary infiltrate seen on X-ray. We call bilateral pulmonary opacity, ground glass opacity, and there is no clinical evidence of cardiogenic pulmonary edema. That is, pulmonary capillary wedge pressure is less than 50. Ideally, we say less than 80. So then we call that as acute respiratory distress syndrome. So classical criteria is what we consider that as a diagnostic criteria. 1, it has to be acute in origin, meaning from 6 hours to 72 hours. Chest X-ray should show you diffuse bilateral infiltrate. And because of infiltration, or we call as protein exudates in alveoli, it will result into severe hypoxia. So PaO2 divided by FiO2 less than 300 but more than 200 we call as an acute lung injury, or short form we call ALI, acute lung injury. But when it becomes less than 200, then we use about ARDS or acute respiratory distress syndrome. Example, here there is an example which is being given. PaO2 is say 60 and FiO2 is say 50, then PF ratio is 120. So it is below this, so it becomes acute respiratory distress syndrome. And if pulmonary capillary wedge pressure is less than 18, then it is definitely acute respiratory distress syndrome. But if it is more than 18, then it is likely to be cardiogenic pulmonary edema. Pulmonary capillary wedge pressure or pulmonary arterial wedge pressure or left atrial pressure, all three are nearly identical. So if any one of this or all the three are less than 18, it is in favor of non-cardiogenic pulmonary edema, or we call as a acute respiratory distress syndrome. So these are the two conditions we call as acute lung injury, acute respiratory distress syndrome. Both you differentiate by only one, that is PaO2 by FiO2, less than 200 ARDS, more than 200 but less than 300 acute lung injury. This is the main differentiating criteria. Now they further divide according to the Berlin's definition. This we already told you that LE, acute lung injury, less than 300, more than 200, but less than 200 ARDS. And then further it is divided into mild, moderate and severe. If you come across between 200 to 300, we call that as a mild, and that should be with, we call PPAP or CPAP, more than 5 centimeter of water, if you are giving that particular at this particular pressure. And if it is between 100 to 200, we call that as a moderate, and if it is less than 100, we call that as a severe. So very simple to remember. If it is LE, it is mild. If it is ARDS, then you divide into two. Between 100 to 200, you call as a moderate, and less than 100, you call that as a severe. So these are those particular things which are very being utilized. That if PF ratio, we call PaO2 to FiO2 ratio, more than 300, by and large we call 0. 225 to 300, 1, score is given 1. If between 175 to 224, score is given 2. 100 to 175, 3, and less than 100, 4. So these are the score given. So if that this score is more than 3 and refractory hypoxia, SaO2 less than 90 for 1 hour on FiO2 of more than 80, then you call that as a refractory. And similar way, there is a persistent elevation of an airway pressure. Depending upon that, you label that as a refractory acidosis if the person has got pH less than 7.1 for at least 1 hour. So these are the different criteria which are being utilized for acute respiratory distress syndrome to group them into different in a severe variety. This is lung injury scoring system. You can utilize chest X-ray criteria, hypoxic criteria, PIP criteria and compliance criteria. And depending upon that, if the score is 0, there is no lung injury. If it is between 0.1 to 2.5, then it is called mild to moderate injury. More than 2.5, ARDS. You will come across good number of conditions which will give rise to non-cardiogenic pulmonary edema like toxic inhalation, near drowning, liver disease, nutritional deficiency, lymphomas, high altitude pulmonary edema, and one of the classical what we are going to discuss today is acute respiratory distress syndrome. Now that adult word is gone. You can divide into ARDS and LE. By and large, we don't use the word adult, we always use the word acute respiratory. Stages wise, that is histopathological classification, exudative, proliferative, fibrotic and recovery. It is divided into 4, those particular. We have already shown you one slide before, lot of different name given to that acute respiratory distress syndrome like Dunning, shock, traumatic lung, weight lung, white lung, pressure lung, etc. There are a lot of different names given to that. But by and large, we utilize ARDS and LE, and then in ARDS, mild, moderate, and severe. Stages wise, exudative, proliferative, fibrotic, and recovery stage. These are the common words which are being utilized for ARDS and LE. We have already given you that mild, moderate, and severe. Between 200 to 300, usually we use the word LE, and that is given a name mild. Between 100 to 200, it is called moderate, and less than 100, we call severe. And this is at the ventilation pressure 5 centimeter. If we divide the etiology, we divide into two groups: direct lung injury, indirect lung injury. Direct lung injury, the most common, which comes topmost on the list, is pneumonia, which is accounting for almost 35%, and aspiration pneumonia, which accounts for 15%. Not common causes: pulmonary contusion, that is traumatic injury to lung, fat embolism, amniotic embolism, air embolism, near drowning, inhalation injury, reperfusion injury, radiation, oxygen toxicity, etc. Smoking does not directly cause ARDS but may increase the risk of development of ARDS. As far as indirect injury is concerned, the most common, which comes topmost on the list, is sepsis. Second common is acute pancreatitis. And third, multiple blood transfusion secondary due to any trauma or shock stage. In that also, there is a chance of getting LE or indirect lung injury. Rare condition in indirect causes: cardiopulmonary bypass, transfusions, drug overdose, DIC, anaphylaxis, etc. So these are the most common causes as far as ARDS is concerned: direct lung injury and indirect. Now if you see in this, putting all together, almost 40% of the cases is because of pneumonia, 22% is sepsis, 8% is traumatic lung injury, and 15% is aspiration. So if you put all this together, they will account for nearly 85% of the groups. 85% of the group. While multiple blood transfusion only 5%, and miscellaneous, or we call as uncommon causes, is 10%. So most common causes is pneumonia, aspiration pneumonia, sepsis, pancreatitis, traumatic lung injury, multiple blood transfusion. This comes topmost on the list. So they usually put A for aspiration pneumonia, R for accidental injury or traumatic causes, D for diffuse alveolar disease, and S for sepsis, whichever way you want to remember. There are certain risk factors which increases the chance of getting ARDS, like chronic alcohol abuse, hypoproteinemia, old age, increased severity and extent of injury, chronic illness, Apache score you can utilize for that, multiple blood transfusion, cigarette smoking becomes a increased risk factor for ARDS. As far as pathophysiology is concerned, we have already told you that there are 4 different stages: diffuse alveolar damage, lung capillary damage, inflammation and pulmonary edema, and last it results into severe hypoxia and decreased lung compliance. If you divide into different phases: exudative, proliferative, fibrotic phase, and then person starts recovering, that is we call recovery phase. We'll be giving you a little idea regarding all these different phases. There is already some pre-existing lung disease like COPD or say bronchial asthma, etc. Or say there is person has developed pneumonia, or person is put on a mechanical ventilation because of severe hypoxia, which may be of XYZ etiology. Because of these two predisposing factor, you develop epithelial injury, or there is an endothelial injury, and there is a decreased cardiac output that will result into infections, pulmonary edema, air leakage, cytokine synthesis, and even a cell death. All these things can stimulate systemic inflammatory response. And once it stimulates the kinase systems, you will have multi-organ dysfunction. So we basically divide into three big groups: acute, subacute, and chronic variety. In acute, there is an exudative inflammatory exudates. It leads to capillary congestion, neutrophil aggregations, capillary endothelial swelling, epithelial injury, hyaline membrane, etc. And it will last for about 3 days, 72 hours. As far as proliferative stage is concerned, or we call subacute stage, where now you get pneumocytes, abnormal laminar bodies, which decreases the surfactant. There is a fibroblast formations, intra-alveolar widening of the septa, which lasts for 4 to 10 days. And then person goes into what we call as a fibrosing alveolitis or a chronic fibrosing alveolitis, meaning there is a remodeling of the collagen tissue, arterial thickening, obliteration of a precapillary vessels, cystic lesions, etc., which starts after 10 days. So there are different stages we call as: first, initially there is increased pulmonary capillary hydrostatic pressure. There is an increased lymphatic flow, fluid transudation into alveoli, and then you start getting different stages depending upon the type of infiltration. So because of diffuse lung injury or damage to alveolar capillary membrane, there is an inactivation of surfactant. Because of that, now there is a deposition or exudation of fluid leading to alveolar collapse, that is we call alveolar atelectasis, pulmonary capillary leakage, interstitial and alveolar edema. Because of all this mechanism, collapse, leak, and edema formation, there is a shunting and stiff lung, and this will result into severe refractory hypoxia. Depending upon PaO2 to FiO2 level, you will call that as ALE or you will call that as ARDS. And again in ARDS you divide into mild, moderate, and severe variety. So these are multiple different mechanisms. They say that because of lung insult there is an inflammatory cells or inflammatory mediators. Because of inflammatory cells you will end up with cell adhesions and molecule formation, surfactant reduction or depletion. And all this has got multiple correlation. You can see the arrow going from one side to another side. Inflammatory mediators will give rise to lung injury, fibrosing alveolitis, that will give rise to SIRS, that will give rise to ALE and ARDS, and end result is death. So there are multiple different mechanisms which are being explained. This is again one variety of explanation of pathophysiology of ARDS, that because of lung injury there is a vasoactive substance activation, that is serotonin, histamine, bradykinin, which will give rise to increased alveolar capillary membrane permeability, bronchoconstriction, vascular narrowing and obstruction, which will give rise to pulmonary hypertension, and that can also aggravate ARDS. Also it can aggravate impairment of the gas exchange because of the obstruction, vascular obstruction. Because of increased permeability, outward migration of the blood cells, different types of cells, that is mainly lymphocytes and also neutrophils. Fluid will come out from the capillary and it will end up with pulmonary edema. We call protein rich pulmonary edema, and that will result into decreased gas exchange. Even bronchoconstriction will also decrease the gas exchange. Because of damage to alveolar cells, surfactant production is reduced, compliance is reduced, it will produce atelectasis, hyaline membrane formation, decreased lung compliance, and secondary to decreased lung compliance, impair gas exchange, and also production of ARDS. So there are multiple different mechanisms which is given, and hypoxia can be because of all these different mechanisms. We call as alveolar damage, diffuse alveolar damage, capillary damage, leakage of edema fluid, inflammatory cell infiltration, VQ mismatch, atelectasis, decreased thorax compliance, there is increased dead space, hypoxic vasoconstriction, etc. All this multiple mechanism ends up with severe refractory hypoxia. And because of that, there is a poor lung perfusion. You will start getting right to left shunting, and that will produce again hypoxia. Lung volume is reduced, alveolar ventilation is reduced, increased work for breathing, and it will end up with hypoxia with hypercarbia. And because of hypercarbia, you will develop hypoxic respiratory acidosis. So impaired gas exchange, decreased lung compliance, pulmonary hypertension, all will lead to resistance hypoxia. So this is slide showing you effect on alveoli leading to infiltration of inflammatory cells, disruption of a alveolar capillary membrane. You can see that alveolar capillary membrane is disrupted, and you will have a leak of protein rich plasma fluid, and there is an inactivation of surfactant. And because of that, now you start getting production of a fibrin that will give rise to fibrotic changes in the matrix, and you will have an accumulation of fibroblasts, loss of functional air spaces, and then it either goes into fibrosis or it goes into repairing stage, or we call it a recovery stage. So injury gives rise to disruption in alveolar capillary membrane, and secondary due to alveolar edema, or we call non-cardiogenic pulmonary edema, which is protein rich plasma fluid. It will lead to resistant hypoxia, decreased compliance, and secondary to severe resistant hypoxia, there is increased mortality. This is a slide which is showing you in detail what are the chemical mediators which are taking part. If you are interested, you can go through your at leisure time. This is normal, what is happening in a normal person. This is what is happening in a person with ARDS. This is showing you further stages, reabsorption of stages. This is cardiogenic pulmonary edema, this is cardiogenic pulmonary edema stage, and this is non-cardiogenic. There is a difference. Here it is a protein poor edema, this is protein rich edema. So there is a different mechanism which is playing a role in a cardiogenic variety, and this is different which is playing a role in a non-cardiogenic variety. Here there is more of pure water. Here there is a protein plus water plus cellular. Macrophages and neutrophils both are seen. There is what is called as a ventilatory induced lung injury and MSOF, that is we call as a multiple systemic organ failure. This is a mechanical ventilation leading to all those biochemical injury, biophysical injury, and then it gives rise to distal organ injury, and then finally it will end up with we call as a modes, or you can use the word multisystemic organ failure, and that is because of biotrauma or mediator injuries. This is mechanical ventilation giving rise to different types of settings. This is complications which can occur: decreased cardiac output, barotrauma, oxygen toxicity, infection, raised intracranial pressure, nasal injury, cuff traumas, etc. There are multiple different infection, injury which can occur because of mechanical ventilation, because that is the most common treatment which you give in a ARDS. Clinical presentation: as it is acute, it is always rapid onset because of severe hypoxia, severe dyspnea, tachypnea. If you measure the oxygen concentration in arterial side, it is severe hypoxia and it is refractory to oxygen therapy. So it is very easy that if any person who has developed severe hypoxic sign, that is cyanosis with signs of respiratory distress, that is severe dyspnea, tachypnea, give oxygen, and if person does not respond properly, do suspect ARDS. And along with that, there is decreased pulmonary compliance, and this is called hypoxemic respiratory failure. And finally, it is ending up with a hypercarbia. So we call hypoxic hypercarbia respiratory failure. Clinically, you will get cyanosis, tachypnea, which is a sign of respiratory distress, grunting sound, or we call expiratory wheeze. There is a retraction of a subcostal space, substernal space, or intercostal. So you get retraction. This is because of increased respiratory distress. There is a nasal flaring. Temperature may be altered. Blood pressure, usually there will be hypotension. Skin will be warm, and that will be one of the features what you come across in ARDS. So severe dyspnea, tachypnea, cyanosis refractory to oxygen therapy, decreased lung compliance, benefit of PEP, possible benefit with steroids, and diffuse alveolar infiltration on an radiology. So these are early signs we have already mentioned. Pneumonia causing ARDS, cough, fever, etc. Late signs, tachycardia, cyanosis, frothy sputum, metabolic acidosis, abnormal breath sounds, crackles, PCO2. If there is tachypnea, carbon dioxide is washed out, person will develop alkalosis in late stages. Because there is a bradypnea, there will be retention of carbon dioxide. Hypercapnia will lead to respiratory acidosis. So there are different stages we call as the exudative stage where there is an hilal membrane disease. In proliferative stage there is an interstitial inflammation, and then there is a release of fibroblasts and fibrosis we call as a fibrotic stage, and then person goes into what we call as a recovery stage. These are the in detail what are the different stages. You get pathophysiological changes, primary and secondary stages or primary and secondary mechanisms. This is when the person develops atelectasis. This will be all the different signs, vital signs wise. Because of atelectasis, tachycardia, increased cardiac output, blood pressure will be elevated. You will have a abnormal ABG, so you will have a hypoxia. CO2 will be reduced because of hyperventilation. Ventilatory rate will increase, means person will develop tachycardia, but person will have a hypoxia. And as far as the PFT finding is concerned, oxygen indices is concerned, radiological finding is concerned, and this is on a chest assessment, on a respiratory examination. These are all the findings you can come across. And ABG wise, decreased pH, bicarbonate level are elevated to compensate, and PaO2 will be less, PCO2 will be elevated in a very severe stage. When the person develops consolidation, these are the changes you can go through at your leisure time. Secondary due to inflammatory process, person will have a fever, tachycardia, increased cardiac output, blood pressure will be elevated. And in a severe variety, again you will have a decreased PaO2, PCO2 will be elevated, means hypercarbia, hypoxia, acidosis, bicarbonate will be elevated for compensation. As you go to increase alveolar membrane thickness secondary due to exudation of fluid, now person will start developing symptom signs where slowly the person will have an acute ventilatory failure with severe hypoxia. Now because of that severe hypoxia, slowly the person will develop what we call as a SIRS, systemic inflammatory response, and then person will go into what is called as a, now this term is mainly utilized, multi-organ dysfunction syndrome. That MSOD, multisystemic organ failure word is now not commonly utilized. So this will be what will be happening on all the different organs. So ARDS is mainly diagnosed by sudden onset. Precipitating cause is known. You usually know the cause. There may be increased risk factors. There is no clinical evidence of heart failure by means of pulmonary capillary wedge pressure less than 18. And if you calculate ratio of PaO2 to FiO2, if it is less than 300 but more than 200, it is called as LE. And less than 200, it is called ARDS. If it is between 200 to 300, it is called mild. If it is between 200 to 100, it is called moderate. and if it is less than 100, we call as a severe. And on an X-ray chest, you get a bilateral pulmonary infiltrate, which is also described as a ground glass appearance. We already uttered all those things here. Same thing is repeated here. So history, physical examination, auscultation, arterial blood gas analysis, blood test, chest X-ray, bronchoscopy, sputum culture, chest CT scan, echocardiography, etc. is very helpful. To differentiate between congestive heart failure and ARDS, in congestive heart failure, you will have an acute cardiac event like MI or acute MR, acute AR. Extremities will be cold, clammy. S3, S4 will be present. JVP will be elevated. You will have a bilateral basal crackles. And if you go through your ECG, you might show a recent infarct or an old infarct, evidence of a ischemic heart disease, ventricular hypertrophy. Chest X-ray will show you bilateral haziness close to the hilum, we call perihilar infiltrates, pulmonary congestion, bat wing appearance, butterfly appearance, curly A line, curly B lines. Cardiac enzymes may be elevated, that is troponin will be elevated. Even you might have elevation of pro-BNP and N-terminal pro-BNP. Pulmonary capillary wedge pressure will be more than 18. All this goes in favor of congestive heart failure. While in case of ARDS, very commonly it is aspiration pneumonia, pancreatitis, and what we call as non-pulmonary injury like sepsis. By and large, you will always have a warm extremities. S3 gallop will be absent. There will be no cardiomegaly. JVP will not be elevated, and lungs will show you by and large signs secondary due to ARDS. ECG will show you tachycardia. Chest X-ray will show you diffuse infiltration and peripheral infiltration. Cardiac enzymes by and large are normal, and pulmonary capillary wedge pressure is less than 80. This becomes a very important thing to differentiate. And in case of ARDS, we'll come across severe hypoxia, where if you do a ratio of PaO2 to FiO2, it will be less than 300, and in ARDS it will be less than 200. And person will have severe hypoxic hypercarbia. In initial stage, it will be hypoxic hypocarbia and tachypnea. So this difference already we have discussed. This is what we have discussed in the previous slide. Again, if there is a cardiomegaly, S3 gallop, JVP elevated, curly A line, curly B line, pleural effusion goes in favor of cardiogenic, while absence of S3, absence of JVP elevated, lack of peripheral edema, normal cardiac size, normal JVP, no curly A line, no curly B line. Usually pulmonary effusion or pleural effusion is absent. We already mentioned all those things. So this is also we have same thing. Whatever we have discussed is put together. At your leisure time you can go through. Whatever we have mentioned, this is clinical findings, difference between the two. This is chest X-ray and this is echo difference between the two. And then pulmonary arterial catheterization. If pulmonary wedge pressure is less than 18, more in favor of non-cardiogenic. If it is more than 18, it goes in favor of cardiogenic. A difference, all the difference given in one simple slide. At your leisure time you can go through. This is difference between hydrostatic, that is what we call is a cardiogenic, and this is non-cardiogenic difference. These are the X-ray. You can see here there is a mild cardiomegaly with hilar pulmonary congestion. You will have a curly A line and curly B line, while here there will be bilateral infiltration. By and large the normal cardiac size, no pleural effusion, No evidence of curly A line, curly B line, etc. Other tests we already told you, BNP will be by and large markedly elevated, or N-terminal pro-BNP will be elevated. In cardiogenic, you can go for bronchoscopy and bronchoalveolar lavage to find out ARDS groups. We already told you pulmonary capillary wedge pressure, if it is more than 18, more in favor of cardiogenic, less than 18, more in favor of non-cardiogenic or ARDS. Pancreatic enzyme to rule out pancreatitis. Liver function test, urine analysis, renal panels, mainly to rule out modes, which is more common with non-cardiogenic rather than cardiogenic. CBC again will help you to rule out more of cardiogenic from non-cardiogenic, because in non-cardiogenic you will have a CBC abnormal. ABG will be also abnormal. You will have a acidosis or alkalosis secondary due to ARDS, depending upon the PCO2 level. In hypocarbia, you will have alkalosis. In hypercarbia, acidosis. You can go for amniotic fluid embolization, where you do LS ratio, we call lecithin ratio, etc. Gastric aspiration, you can go for. So in aspiration pneumonia, you can look for that test we call LS test, or lecithin sphingomyelin ratio. Chest X-ray by and large is good, helpful. We already mentioned the difference between both variety, ARDS and cardiogenic variety. You can go for severity of hypoxia by calculating arterial blood gas, that is oxygen level, to FiO2 level. BNP, we have already told you that it will be less than 100, almost rules out what we call as cardiogenic variety. Usually BNP level is less than 100 in a person with ARDS. Bronchoalveolar lavage you can go for and look for neutrophils presence in ARDS, which will be positive. Protein level will be also elevated in case of ARDS. It will be more than what we call as 0.7. Echocardiography will give you more idea regarding a cardiogenic than non-cardiogenic variety. In a cardiogenic variety, valve abnormalities, left ventricular hypertrophy, left ventricular ejection fraction reduce, pericardial disease, etc. you can identify by doing a good echocardiography. Swan gas catheter will help you to identify pulmonary arterial wedge pressure. If it is more than 18, cardiogenic; less than 18, more in favor of non-cardiogenic. You must always differentiate cardiogenic from non-cardiogenic, and there are many other conditions will also give rise to pulmonary edema. You should try to rule out those groups. Once you confirm the diagnosis of ARDS, you should manage, because there is no specific treatment. Main treatment is a supportive line of treatment. You have to maintain good oxygen concentration. For that which you require an artificial ventilation, and you require a supporting line of treatment. If possible, if you identify the cause, you can treat the underlying cause. Mainly the person has to be treated for hypoxia. Supported means oxygen plus ventilation and adjuvant therapy. So ventilatory management, treatment for refractory hypoxia, and supportive treatment. So while treating non-cardiogenic edema, usually we call resuscitation for ABC, and then treat underlying cause depending upon the etiology. So treat the precipitating cause. Person should be in ICU. He requires good quantity of oxygen, good concentration of oxygen. Ventilatory support is almost needed. Adjunct to ventilatory support, you give another treatment. There is treatment for inflammation, anticoagulants, rehabilitation, and recovery stage. For infection, antibiotics, drainage. In aspiration, again prevent recurrence. In drug induce, stop the drug which is producing the damage. In case of a fracture, operative fixation. In pancreatitis, treatment of pancreatitis. In suspected sepsis, you can give empirical antibiotics. These are all the things which you do in case of ARDS. There is a non-invasive ventilation. You can go for different types of ventilatory protocols. You can give different varieties of ventilations. There are a lot of different types of ventilation given. For refractory hypoxia, you can go for a prone ventilation. You can go for even inhaled nitric oxide, ECMO, etc. As far as a non-ventilatory support is concerned, fluid management, diuretics, steroid, blood transfusions, inotropic agents. There are many different things which are being done. So there are a lot of treatment. Treat the predisposing factor, fluid replacement, hemodynamic management, nutrition, lung protective ventilation, non-invasive ventilations, pharmacologic therapy, they are called rescue therapy. So these are lot of different modes of treatment what are being done. You give oxygen, you give mechanical supports, mechanical ventilations, different positions, supine, prone position, fluid therapy. This we already mentioned: antibiotic, anti-inflammatory drugs, corticosteroid, diuretics, inotropes, anti-anxiety drugs, muscle relaxant, bronchodilators, etc. These are all the things what are done during mechanical ventilatory supports. And there are all different modes of giving those. You can give permissive hypercapnia, light tidal volume, open lung, HFOV, total gas insufflation, total implantable artificial lung. Then you can go for IVOX, IV gas exchange. You can go for pulmonary vascular change, ECMO. You can go for INO, that is nitric oxide, PLV, prone position, surfactant, anti-inflammatories, etc. These are all the different treatment which are being utilized. These are all the things which are mentioned in detail regarding ventilatory supports, treatment of ECMO. You can go for ECOR, high frequency oscillatory ventilation, inhaled nitric oxide. These are all the different treatments. But basic mechanical ventilation followed by ventilatory adjuvant, fluid therapy, drug therapy, and last is ECMO. This is prone position, supine to prone position. It will increase your ventilation. This is prone position ventilation. There is an improvement in oxygenation. So this is half prone, not complete. This is also called as Wallman prone positioners. Then you further completely prone position. There are beds which are available which can turn. You don't have to turn the patient. While giving mechanical ventilatory supports, always look that you don't provide any injury. You don't induce any injury to the lung. So we call as a barrow, injury should not be there. These are all the different ways of giving the different types of ventilatory supports. At your leisure time, you can go through. In a refractory hypoxia, you can go for prone position, different modes of ventilators, IRV, inhaled nitric oxide, ECMO, etc. These are all the different words which are being utilized. If you are interested, you can go through. The person who is working in an ICU will be benefited. These are adjuvant therapy. You can go for fluid vasopressure. Ventilation we already mentioned. Anti-inflammatory like corticosteroids, cyclogenase inhibitors, pentoxifylline, antioxidants, anticoagulants, protein C, glutathione. partial liquid ventilation, anticoagulation. There are a lot of different, these are big list. You can see there is a big list. They even give statin, aspirin, ACE inhibitor, insulin, vitamin D, complements, stem cells, growth factor, gene therapy, prostacyclin, ibuprofen, N-acetylcysteine, mucolytic, albumin, etc. But you can understand if there are multiple choice, none is effective. As far as complication is concerned, the most common complication we always should mention is person may not recover and person succumb to death. Very, very high mortality in ARDS if not diagnosed early. But because of now good ventilatory support, the mortality rate has come down. Person will develop restrictive lung disease because of a fibrotic stage. So in a recovery stage, usually person develops fibrosis and person will develop irreversible damage, that is restrictive lung disease. Some of the people develops chronic obstructive pulmonary disease. DLCO is reduced and there will be also chance of complication if ventilation is not given properly. So they can develop barotrauma and other complication of ventilation like infection, acute ventilatory induced lung injury, etc. Really. So nosocomial pneumonia, barotrauma, renal failure, oxygen toxicity, stress ulcer, tracheal ulceration, blood clots, deep vein thrombosis, pulmonary embolism, etc. are the common. This is what we call as a continuous diaphragm sign. You can see that you can separate the pericardium or heart from a diaphragm, and this is because of pneumomediastinum, secondary due to barotrauma, which can occur because of mechanical ventilation, and the name given is continuous diaphragm sign. You can make out the continuity of the diaphragm. By and large, in a normal person, you cannot separate the heart shadow from diaphragm. Here you can easily separate that, and this is because of pneumomediastinum, not pneumoperitoneum, pneumomediastinum. So I end my lecture here of ARDS. I hope this will be helpful to you, and the person who is working in an ICU, this will be definitely helpful.